go ahead.
Yeah.
Okay, well, greetings to everyone. It is a sincere pleasure and honor to have this wonderful opportunity to present at Evidence to Impact for the International Society for Evidence-Based Healthcare. My name is Dr. Eddy Lang. I am the head of emergency medicine at the University of Calgary, and very pleased to be with you today. I am joined by two other emergency physicians in training, so emergency medicine is well represented in this session. We also, as emergency physicians, generally make sure we know where the defibrillators are in the room in case there's an emergency, but that seems to be maybe less relevant with the virtual format. But nonetheless, we're so thankful that you could join us, and I just wanted to congratulate Professor Lubna Al-Ansari for a fantastic looking program and for the very generous invitation, coordination, and support to make this happen. The topic for this panel is overdiagnosis, and it's going to be perhaps a little bit different than some of the other subjects that have been presented. Overdiagnosis, as I will try to make the case, is a challenging but emerging topic that has repercussions, I think, on patients and on our future, on the future of healthcare. And it's in that regard and in that spirit that we've developed this panel with Marisa Vigna, who is not only a first-year emergency medicine resident, but worked on overdiagnosis projects when she was a medical student, and importantly served as a patient and family advisor. And of course, Carina, her sister, has also been interested and helped out in this and will represent the medical student perspective. So I just wanted to start with some relevant information about me and how this topic came about. I was first made aware about overdiagnosis through my work at the Canadian Task Force on Preventive Healthcare, where I sit as one of the panelists. The Canadian Task Force is our country's national body to make recommendations on screening and other preventive health measures, and they are very much concerned about the problem of overdiagnosis, especially as it relates to cancer screening, but other areas as well, including screening for mental health and other conditions. So we also wanted to let you know that over the last few months, Marisa, Carina, and I, as well as many others, had the privilege of hosting the Overdiagnosis Conference in Calgary. And you can certainly visit the website and see some of the sessions that were held. This is an international annual conference. We had the privilege of hosting it in this past summer months of June, and it's going to be in Copenhagen in August, again in a hybrid format. And I was very fortunate to have the privilege of being the chair of that conference. And just a quick word on how international our panel is today. I know most of our audience is based right now, perhaps in Saudi Arabia, in Riyadh, but I'm coming to you from Brazil, even though I am from Calgary. And we have Marisa and Carina coming from Ontario and New York, respectively. So in this time, I'm going to talk about what overdiagnosis is and how it relates to other troublesome concepts that create harm in healthcare. It touches on over-detection, detection that's not helpful, shifting disease definition thresholds, and something we call disease mongering, which is raising fear about contracting a disease that may not be real or may have false incentives. And of course, you can see the Choosing Wisely Canada logo on this slide. This topic of overdiagnosis, of course, interfaces with low-value care and some of the problems we see around diagnostic test accuracy, although overdiagnosis is different than diagnostic test accuracy and is not captured in the typical measures that we use, such as sensitivity, specificity, and likelihood ratios. And you're going to get all of our three perspectives on what is driving this global threat to health and sustainability, which we think is overdiagnosis, and also start to talk a little bit about where the solutions might lie. So maybe I would ask for you to consider this question to start thinking about overdiagnosis. And the question is it possible for a citizen, and I use the word citizen because before you become a patient, you're a citizen, can you be harmed by undergoing a test, even if that test has very good performance characteristics? Or if you are told by a healthcare provider that you receive a diagnostic label, even if it's ostensibly and technically an accurate one, can you be harmed as a result of that process? And maybe you would want to think of some examples. I don't see a chat window, but if you wanted to share that with the other people in the audience, that would be great. And, you know, I think it's important that we take this back to the patient level. So I have a few scenarios to describe for you that will hopefully illustrate this problem of overdetection and ultimately overdiagnosis. So first we meet Alfred, who is 65, is unfortunately undergoing an unhappy divorce. He's lonely, he's despondent, and he will attribute the problems to complications of prostate cancer surgery. You know, he was advised by his primary care physician to undergo a routine prostate-specific antigen test. That came back positive. It led to a biopsy and resulting in the diagnosis of a low-grade tumor. He was told that he could do watch and wait, but he was very concerned about the findings, and he opted for a prostatectomy, and that led to significant complications which affected his marriage. Pamela is suffering from severe anxiety. She's 27, and she's not able to complete her studies, and her problems go back to an abnormal finding that was discovered on CT MRI. She was experiencing migraines, and the frequency and pattern had changed, and her physician elected to order imaging to make sure that nothing was being missed. And an abnormality was identified. It was not amenable to a biopsy, but it created a lot of angst and anxiety for Pamela, leading to these problems. And although there was not progression of the lesion for 3 years, and it was deemed to be a normal variant, this was ultimately an incidental finding, but still through the concern and anxiety caused a great deal of harm. And I would just add that both Alfred and Pamela may not have appreciated or understood or received a full understanding and consent of the risks of undergoing the PSA and, in this case, the neuroimaging. Finally, Sam is a 24-year-old who has been diagnosed with attention deficit hyperactivity disorder and has been taking medications on and off for years. He struggled with schoolwork in his teens, was referred to a psychologist for testing, and was actually diagnosed with attention deficit disorder, but without hyperactivity. The medications worked extremely well at the beginning. He had a remarkable early effect, but later developed anorexia, anxiety, and depression every time he stopped the medication. So we are in a unique situation as far as overdiagnosis is concerned, because although there was a fair bit of uncertainty as to what exactly this was all about, recently, last fall in the BMJ, the official definition was published, and I'll just allow you to see some of the highlights here. The key concept is that you are putting a label on a person. Either it's a disease or it's an abnormal condition, and it would not have caused the person harm if left undiscovered. So this occurs in a number of ways: medicalizing normal life experiences, expanding existing diagnoses by lowering thresholds and widening criteria. There's no benefit from overdiagnosis, but there are harms that can be physical due to surgery or necessary surgery or treatment, psychological, as we saw potentially in the case of the young man, or financial harm by losing work and staying away from school. These are some options, ideas for how overdiagnosis can occur in emergency medicine, but I will let my co-presenters go into that in more detail. This infographic will speak as well to some of the more factual basis for the problem of overdiagnosis. 1 in 3 prostate cancers detected through PSA testing would have never caused harm had they been left unknown, but yet many of them lead to debilitating treatments and surgery. So that's quite a very high rate of overdiagnosis. It's similarly quite high in breast cancer screening, especially in women below the age of 50, and it's why the Canadian Task Force has recommended against mammography screening in the 45 to 50. It's not a strong recommendation against. It should be based on informed consent and shared decision making, but the risk of the tiniest, the benefit, the small amount of benefit is, in our view, and in the patients that we spoke to develop the guideline, overshadowed by the harms of overdiagnosis. And it's probably one of the reasons why neither prostate cancer or breast cancer screening has ever demonstrated a reduction in all-cause mortality. There is a small reduction in disease-specific mortality, but not in all-cause. Overdiagnosis is a rapidly emerging field. It's a new mesh term, also within the last year, and you can see by the graph, the number of studies that are talking about overdiagnosis is increased exponentially, and now there is almost 5,000 papers. Important to distinguish from misdiagnosis, which is something else, and even underdiagnosis, which is, of course, different and we can address. This graphic shows where we've identified the problem of overdiagnosis. It occurs in the skin, over on the bottom left-hand side of the slide, with relation to melanoma, often attributed to higher levels of ultraviolet light, but may actually, and is probably likely related to overdetection. And you can just look around this figure showing how, whether it be in mental health or in lung cancer screening or in non-alcoholic fatty liver disease, we see now the popular trend of screening for atrial fibrillation. All of these approaches increase the risk of finding something that may be of some indirect benefit to a drug manufacturer or a surgical instrument manufacturer, but is not going to benefit the patient. And it's an inevitable part of diagnostic evaluation, of course, but are the risks and benefits clearly laid out at the get-go? This is a figure that demonstrates how complex the problem is and how it relates to various layers within our healthcare system, including the culture that many of us encounter from that is widespread, that the more tests, the better, that early detection is better. And that then infiltrates through patients, public health policy, health professionals, health system, creating a whole bunch of problems. I believe you're going to have a more in-depth look at this slide from the student and the patient perspective in the next little bit. This is a tool that we use at the Canadian Task Force for Preventive Healthcare to show to patients what exactly is the risk of overdiagnosis and how out of 1,000 people who go for a PSA test, most will not derive any benefit or any harm, but of the 178 who will require follow-up, there is a significant risk of complications related to biopsies, and then if you're found to be positive, the proportion who will have overdiagnosis. So what is the epidemiological signature of overdiagnosis? This came from Korea and published in the New England. In 1999, the government of Korea opened the door to having physicians perform thyroid ultrasound in their office and make it an act that was remunerated. And what happened was quite unusual and quite dramatic. There was a very rapid increase in the incidence of thyroid cancer. However, you would expect if the overall incidence would increase, so should the mortality. But the mortality did not change, suggesting here that more was being discovered as a result of overtesting and overdiagnosis, but it was not a reflection of an increasing incidence or prevalence. It was more likely related to the changes in practice. However, in March of 2014, a group of Korean physicians, and this is now getting to what maybe are some of the potential solutions to the problem of overdiagnosis, developed a coalition to say, hey, we have to stop screening for thyroid cancer because clearly we are doing more harm than good, and this is being driven as a perverse incentive which is ultimately harming our patients. And sure enough, this campaign was effective at reducing the number of patients who underwent surgery for what were ultimately benign lesions or indolent lesions that would have never have come to fruition or caused any problems. So I will just finish with a few thoughts before passing on the baton to Carina. Because we are talking about overdiagnosis does not mean that we are not minimizing the problem of underdiagnosis. In fact, they may be related. We think they are because of the amount of resources that are directed and consumed through the problem of overdiagnosis that leaves less resources available for those who are truly in need. It's an important healthcare harm, and there's lots of literature and videos and things to read about this, but it's still very challenging and difficult to understand. It's widespread, we believe, rampant and insidious, and it's something that's not particularly well explained to both students, nurses, and the public, and maybe it's something that raises conflict of interest issues and that is not well described. But there are avenues to improve it, and we'll hear more about that and work forward to your thoughts as well. So I will stop there and pass things over to Dr. Vigna, Carina Vigna, for the next phase of the presentation. Thank you.
Thank you, Dr. Lang, for the excellent overview on overdiagnosis. I'll just wait for the slides to come up. And the other Dr. Vigna, so Marisa and I are going to be kind of, for the first little bit, switching between each other. So I'll kind of introduce what we're talking about and we'll go from there. All right, so we are going to be discussing overdiagnosis, which is, creating harm in the pursuit of health. And we're going to be presenting a few different topics briefly that we see in the ED, but in the emergency department, but it is relevant to other areas of practice. And we're also going to be presenting the patient and medical student perspectives. All right, so.
So this is our disclosures. Carina and I, we don't have any disclosures to share. Mm-hmm. And this is just a brief outline of our session, our portion of the session. And thank you, Dr. Lang, for your introductions there of explaining overdiagnosis. And so, as mentioned, we'll go into a little bit more depth with 3 different examples specific to the emergency department, and then bring in the patient advisor and medical student perspectives.
All right. So I'll just start by going quickly over the objectives. So we want to promote an understanding of overdiagnosis, which Dr. Lang already touched on, from multiple and diverse perspectives. We are going to briefly explore 3 pertinent overdiagnosis issues that are relevant to medicine, and then give an overview of the salient literature. We'll also reflect on the potential harms associated with providing certain diagnoses. And we're going to see, where this is going in the future and the next steps to lessen the impacts of overdiagnosis.
So I know that Dr. Lang did show this slide, so I'm not going to go into too much detail, but really it demonstrates that overdiagnosis is quite prevalent, and there's research in areas in cancer, mental health, asthma, ADHD, as Dr. Lang alluded to. But there seems to be quite a bit of a gap when it comes to overdiagnosis literature in emergency medicine. And so that really brings us to why we'd like to shed some light on this particular area today during this talk, and provide some food for thought for some of you as well, based on the available literature and research at this time.
All right, so the following 3 examples that we're going to briefly discuss were chosen given their prevalence in the emergency department, but this is not just solely an emergency department issue. They're current topics of discussion in the literature on overdiagnosis, but they're still, these areas are still lacking breadth and depth. We did recently publish a paper discussing these 3 examples in a little more detail. So these examples provided demonstrate how applying a diagnosis on a clinical grounds or clinical basis alone can lead to overdiagnosis.
Perfect. And before we get into the 3 examples, if anyone has any questions or comments, please, we welcome you to share them either in the chat or, if able, to ask questions through the question and answer feature.
We can also, at the end, if you want to save your questions for the end, you can go ahead and do so as well. All right, so with anaphylaxis, this is our first little point here. So the number of dispensed auto-injectors like epinephrine or EpiPens have increased in the past decade. A diagnosis of anaphylaxis is made to prevent an unlikely fatal outcome, which is death. And incidence of anaphylaxis has been increasing steadily, and it may be a challenge to incorporate with changes in potentially population atopy.
So we do know that most of these auto-injector prescriptions are justified, but some of them may have been written for patients that have presented with some significant allergic reactions and possibly some respiratory symptoms as well, such as throat tightness, but maybe was never actually confirmed soft tissue narrowing, or even manifestations of angioedema, which are all prevalent pieces to diagnosis of anaphylaxis. But yet, out of an abundance of caution, we end up making the diagnosis of anaphylaxis, because of course it can be fatal if not. And of course then as well, patients go home with an epinephrine auto-injector pen, and usually there's follow-up with an allergist as well as their primary care provider if possible. So it leads to a whole other route of further involvement and striving deeper into the healthcare system for maybe something that never needed to be in the first place. And so these are just some thought-provoking questions that we have as along with our presentation, just to have any thoughts. If anyone has any comments to them, again, feel free to share them now or at the end of the presentation. But we think about, is it possible that as physicians, are we contributing to overdiagnosis of anaphylaxis? Are we continuing patients on a lifelong of using EpiPens or making sure that they're always available, creating unnecessary anxiety with this diagnosis?
All right, now we're going to talk a little bit about subsegmental pulmonary emboli, another hot topic in the emergency department and beyond. So in general, emergency medicine physicians operate under the thought process that we are supposed to avoid missing a large and a potentially life-threatening PE, as opposed to thinking of not treating a small PE. So with the advances in technology, there's an increase in sensitivity of our CT imaging. CT scans can now, detect smaller and smaller thrombi, and this leads to an increased prevalence of detecting a PE, and therefore more treatment. And this treatment is anticoagulation. There's obviously, pros and cons to prolonged treatment with anticoagulation. And then there's always a patient's fears. The patient fears anxiety of a recurrence of a PE. And what if the next one's bigger or more deadly?
And that leads the physician on the other end of saying, well, now we've found this subsegmental pulmonary embolism, but it may not have led to any harm had it not been detected. But now the question is do we lack the confidence to ignore it altogether? Because what if it does become something significant? Do we need to treat it? And so with this detection of a pulmonary thrombus, even if it's smaller, some form of a normal variant, we often do tend to treat it. And so again, it leads to another question of, can treating a patient with a prolonged course of anticoagulants actually in fact be more risky than the potential for recurrence altogether? And this leads us into our final of 3 examples, which is low-risk chest pain, another very prevalent, of course, presentation into the emergency department. And so many times we exclude acute coronary syndrome as the primary issue. And after that, we refer them on for additional testing in the community as an outpatient, which often involves things such as stress testing. And that could potentially lead to findings of ischemia without even a history of having any atherosclerotic disease. And at this point, then we start to think, well, could patients be enduring a diagnosis that has come many years before it would typically would have even been discovered? Can that cause more harm than good? Are we labeling people as a cardiac patient many years before they ever needed to? And what implications might this have? Things like insurability, quality of life, impact on well-being. And really, studies have shown that early non-invasive testing within a 30-day window of emergency department acute coronary syndrome evaluation may result in, at best, minor reduction in myocardial infarction or mortality risk.
So this poses an ethical dilemma for emergency medicine doctors and any physician really, or anyone in healthcare, that there's risks of acute coronary syndrome if a patient is discharged with potential harms that could result from cardiac workup. This highlights the need for reassessing the current guidelines, maybe developing some new risk stratification models and ensuring that patients understand what their options actually are and some of the pros and cons involved with doing this cardiac stress testing and beyond. So just a few more questions to think about. Do physicians effectively determine risks associated with giving a diagnosis when a patient presents with chest pain? And what are the potential fallouts from the treatments? And do physicians ensure that the patients understand what their options truly are when it comes to this early testing?
Okay, now I see that there is a question. Do we want to take a moment to pause? And Dr. Lang, would you like to answer this question, or shall we wait until the end?
Yeah, we could make it more interactive, so I'd be happy to step in. It's a really excellent question about how to balance between over and under diagnosis. And I think when we talk about underdiagnosis, I think we all appreciate that that's clearly a very important problem. It often refers to vulnerable and marginalized populations or people who work in under-resourced healthcare settings, be it in rural environments or other settings that are not well funded. And I think that if we were to pay more attention to the problem of overdiagnosis and consider what resources are being consumed by this problem, it could, in theory, free up more questions. But I think when it comes to the individual patient, if you are balancing the risks of testing and discovering something that would then become overdiagnosed or an incidental finding, for example, I think the key piece is really about engaging the patient in shared decision-making. And although patients often want to be tested, they want the reassurance, they associate good doctors with doctors that do more tests, I think it's time to change the culture of that interaction and maybe present to the patient that actually doing a wait and see or not necessarily getting to the very bottom of everything is the right way to go, or maybe just more important than making a diagnosis is the road to recovery from whatever perspective that is. So if there's a good consenting discussion and shared decision-making, that may be the best approach at the individual level to balance between over and under diagnosis. And the other things that we talked about relate to the system issue. So I don't know if you, Marisa, Carina, you wanted to weigh in on that as well? That was my thoughts.
No, I think that's perfect. And I think some of it will also come up in this next section as we talk through our perspectives as well. And we definitely bring in the idea of shared decision-making being fundamental to kind of how we proceed forward with each person. as each as a separate case specific, not kind of a one catch-all for all people. So I think if no other questions at this point, we'll continue on and kind of pivot now from our conversation about the evidence side of and aspects of overdiagnosis and transition our focus more towards the patient advisor and then subsequently the medical student perspectives. Just as a means of adding further insight into the relevance of overdiagnosis to other pertinent stakeholders. Of course, in our opinion, the conversation on overdiagnosis would completely be remiss without having and considering the people that we serve on a daily basis, which is our patients, as well as the future of the medical profession, some of which, of course, are our medical learners. And so, as a patient and family advisor for over 15 years in a variety of capacities, I've had experience working with patients and, of course, their families to understand their values, perspectives, and preferences related to a wide range of healthcare encounters. And as such, I would like to share some of this with you now. And so again, Dr. Lang did show this slide before, and I think it kind of is important to look at some of these different aspects of what's driving overdiagnosis. And many of these are somewhat unintentional, especially at the society level. It's designed to allow for patients to have a wealth of experience at our fingertips now. Dr. Google is always readily available with what appears to be many of the answers and management plans for common healthcare concerns for patients and people. This in and of itself is possibly creating a culture where there's a lot of self-diagnosis occurring and over-reliance on testing and treatments, which are not always benign. But of course, that part isn't usually mentioned on Dr. Google. Additionally, there's a belief that early detection is beneficial. And yes, that sometimes can be the case. However, what the public often doesn't realize is the harm that comes as a result of unnecessary diagnosis. Invariably, unnecessary and potentially harmful labeling, and then subsequently low value and harmful treatment of patients can create stigma and ultimately impact quality of life. Patients and the public have not been taught to critically judge or approach the various bombardments of messages they receive. And as a result of this, they often fall victim to the mindset, as Dr. Lang alluded to, that more is better, but this is just propagating the problem. So with this in mind, it really begs the question of, has the time come to rethink what messages physicians, public health officials, and the media are providing to patients and the public? And this is one of these quotes that I love by Dr. Welch, that when we think about health, it's more than just the absence of disease. It's about how people feel, and it's a state of mind. And so really thinking about what the patient feels is very important in these situations as well. And so I really believe that the question kind of boils down to, like I just said, how patients feel about all of this. And as a patient and family advisor, having many conversations, the messages I've received have been quite unanimous. Firstly, the importance of the patient-physician interaction cannot be underestimated. Patients wish to be treated with dignity, respect, empathy, and compassion, as this creates a sense of security when they are most vulnerable. Though receiving a diagnosis can sometimes be reassuring, patients usually want to be informed about the potential harms and the negative impacts of a diagnosis that can have on their life. However, if the physician doesn't take time to initiate this discussion, patients don't typically think to bring it up about the harms associated with maybe a diagnosis they're receiving. As well, patients face challenges all the time about feeling intimidated when attempting to say no to a doctor who is trying to achieve a diagnosis through more testing, at the expense of being made to feel irresponsible and to avoid the possibility of falling into the, well, would've, I should've, could've pattern of thinking. Patients often succumb to additional testing. If testing and diagnostic uncertainty are discussed in greater depth through shared decision-making, potentially undue harm may be prevented. Additionally, patients appreciate being educated on the importance of sometimes just waiting and that passage of time, and how sometimes their experiences can be normalized, of course, in the appropriate context, which can be imperative in both the decision-making process as well as their recovery. And this leads me to my final thought about ultimately, if patients are better able to become active participants in the pursuit of a diagnosis, then I believe patients believe as well that a better quality of life can be achieved overall. While engaging in shared decision-making, Patients would prefer that physicians consider their values and their perceptions of risk, which of course is different for everyone because patients come from very diverse backgrounds, the varying levels of health literacy and numeracy, differing views, differing beliefs, differing experiences, and variation will exist in terms of their willingness to understand and ultimately accept uncertainty. This ultimately impacts the level of involvement, of course, and the decision-making within each person's care. And we need to take this into account because patients would like physicians to be flexible people and be able to adapt to patients' wants and needs by adjusting testing strategies and clinical decision-making appropriately, as one size does not fit all, and really thinking about the patient is a person before a disease. Patients really just want doctors who are genuine human beings, people who can move forward together and work as a team to have a vested interest in what is best for the patient. After all, it is much easier to work together, and when doctors are willing to admit that they are uncertain about a diagnosis and are prepared to discuss potential options, as well as risks and harms and benefits associated with each, rather than quickly labeling a person with a diagnosis, I believe that ultimately we'll be achieving a better quality of care.
I'm going to talk now about the medical student perspective, and what Marisa was saying. You know, this all sounds great, but how is one expected to educate patients on overdiagnosis when many doctors themselves don't have the knowledge and understanding of what overdiagnosis is and the harms caused by it? So if well-seasoned doctors or people that have been in the field for a long time don't have this knowledge and understanding of overdiagnosis, then what can be expected of medical students? Although we can't speak to medical education around the world, in our experience as students in North America, overdiagnosis was alluded to just briefly. It was touched on very slightly, but it wasn't ever, the focal point of learning. In fact, another interesting realization to highlight this came when we took time to search the term overdiagnosis and try to get a bigger understanding of it in reference resources commonly used by ourselves and other medical students. So we looked up, up to date, Dynamed, Toronto Notes, some of these big resources, and all of them only briefly mentioned the term, mostly in relation to cancer screening. I mean, that's a big area, but it was very brief, very short, not much expansion into other areas. So from our experience, medical students often have the luxury of having time to spend with their patients, as opposed to other healthcare providers. They have time. They don't have the amount of responsibilities that other providers would have. So as a result of this, they're uniquely positioned to encourage shared decision-making with their patients. And this underscores the importance of helping medical students understand that not everything that is done to a patient, even if it's a well-intentioned treatment, will benefit these patients. So it's our hope that the concept of overdiagnosis will be embedded into future curriculums alongside current teaching on clinical decision-making, and also utilizing diagnostic testing appropriately, which is not always the case nowadays. This also ensures that medical students, can be given the opportunity to better understand overdiagnosis at an early stage of their training, where they're more amenable to differing perspectives. So building good habits early on in medical training, by reframing medical student thinking to more intentional consideration of next steps, should become the norm. Rather than quickly jumping to the safety net of, oh, let's just get more investigations done, do more imaging, even if we're not sure of the basis as to why we're actually doing that. Wouldn't it be better if medical students began to ponder questions like, are investigations even warranted for this patient at all? Or which ones are the best ones to get in this situation? It doesn't necessarily mean check off everything in the panel. Or will reassurance be the next best step for this patient? Or will engaging in shared decision-making be the best option? If medical learners begin their careers with this mindset, then we truly feel that the culture of medicine can change down the road. All right, so now we're going to go into our next steps and just talk a little bit, but this will be more interactive in the back half of it. So overall, based on what we found in the literature, we were left with a lot more questions than actual answers. I think some further research needs to be done to determine the extent of the problem in overdiagnosis in many areas of medicine, not just emergency medicine. So I think we've, looked at some ideas here, like additional research to help inform development of evidence-based approaches to risk stratifications, guideline developments, protocols, and designing different decision-making tools with the patient-focused outlook. And then focusing attention on patient management rather than diagnosis prioritization. So not jumping to a diagnosis right off of the top. And then adapting medical training to emphasize shared decision-making, like I discussed, and then treating the patient before the disease. So I think those are some important things. And then we'll just move on to some discussion questions.
So I think there are 2 questions actually in the chat. So maybe we'll take a few moments to answer those questions. And then if there's some time, we can go into some of our own discussion questions as well.
So Dr. Al-Tahan is writing about the problem of overtreatment, and there's unbelievable treatment protocols for early stage cancers that seem to be in excess. And I think that's a very good point. Overtreatment is a distinct problem. And it's certainly, we see it in emergency medicine through the overuse of antibiotics as an example. A lot of that can be traced back to overdiagnosis, but clearly some of it is with appropriate diagnosis as well. So I don't know if Dr. Al-Tahan would like to be able to join the conversation and make their comments about what they would like to say about overtreatment. It sounds like this is in the realm of oncology, but I'd be interested in hearing more. So I don't know if that's possible to join the conversation, but do you guys want to maybe just move on to the next question? Is medical student syndrome an aspect of overdiagnosis, or does it contribute somehow to the culture of looking things up and turning over every stone and contribute and causing overdiagnosis that way? I don't know if you want to Marisa or Carina, you want to take that one?
Sure. So I can start, and if you have anything to add, Carina. I do actually think this is a really great point, and I love the medical student syndrome comment that was made here. I do. At the current point and how we are trained, or at least in my experience, oftentimes we are kind of told to look at everything and make sure that we're taking time and looking at every little detail and trying to find every little explanation for why a hemoglobin might be, dropping 15 points or things like that. But in actuality, we don't take time to actually think through, does this even matter in the bigger context? And I think you're absolutely right. The current teaching model right now is we have to diagnose everything. And so this is why Carina and I truly believe that the whole culture needs to change, and a mindset shift needs to occur as well, where we bring up questions like this and we talk through cases where maybe doing more is actually creating more harm for the patient, rather than taking a step back and thinking about, will this ultimately impact a patient's quality of life in a good way or in a bad way? And so I do, like I said, completely agree with you. As the current model of teaching is in effect, we are creating or we are part of the spectrum of overdiagnosis, but we do hope that will change in future. Not sure.
I just want to add more from now having been a medical student and now being a resident in a very underserved hospital in East Brooklyn in New York, where the patients come in with a wealth of diagnoses. Each of them have astounding actually to see what some people come in with. They haven't seen a doctor, they don't have primary care doctors, they don't have the time or accessibility to see a doctor all the time. So when they're coming into the emergency department, they're very sick. And we tend to want to get everything for them when we should be realizing that not all of these patients will benefit from every diagnosis thrown at them, nor will they be able to follow up with every healthcare provider required after getting these diagnoses. So it becomes a challenge in that regard. And just one patient is going to, with every diagnosis that we give them, have so much time spent on that when we have an emergency department full of patients that have concerns as well. So that was just an eye opener for me, coming from the medical student into what's actually happening in the real world as a doctor, just to throw that out there. So we are overdiagnosing our patients a little bit, and I'm not sure it's benefiting patients overall, but especially not in a very underserved area like mine.
And we also got some really good comments about the medical legal contribution to the problem. People don't want to make a mistake or miss something or be getting into some sort of trouble after the fact. I think that a lot of that could be addressed again with a good discussion and elaboration with the patient, and of course documenting it in the medical record. But if the risks of finding something that would best be better left unknown, and it's hard to get this across maybe, but it's sometimes better not to know. And if a patient is in agreement with that, and that is documented, and even if something is missed and some negative outcome occurs, it's a terrible thing to happen, but at least from a medical legal perspective, if there was a clear agreement on the plan of not to perform a given test, and the system can protect you if the documentation is clear, that might encourage a more shared decision-making approach. Thank you.
These are really good questions, and it's a good discussion right now. I mean, we do have a few discussion questions we can pull up, and maybe that'll inspire some more questions from the audience as well. So initially, is there a potential explanation for the upward trend in diagnosis of certain medical conditions, not just the ones that we mentioned today, but other ones as well? Maybe you can think of some right now that you want to discuss. And then, can a patient be harmed when receiving an accurate diagnosis that entails a preventative or therapeutic management strategy? Is there too much of an emphasis on formulating a diagnosis as a medical student? And how can we increase awareness of the potential negative impacts of overdiagnosing patients?
One thing I'd like to point out is that clinical practice guidelines can contribute to overdiagnosis. And we saw this very clearly when the American Heart Association revised its criteria for what would be considered high blood pressure. There was a lot of criticism that the expanding threshold and lowering the threshold was justified because the research to show that outcomes were improved was very tenuous. And of course, there were a lot of conflict of interest issues related to the guideline, both financial from the sponsors as well as professional. I mean, people whose lives are based and careers are based on treating high blood pressure will not surprisingly have a bias towards wanting to lower the thresholds and treat more aggressively. So we have to watch out. And there's a group at the Guideline International Network that's tackling this issue, the disease definition and disease threshold issue. But that we have to be very careful about how this is potentially affecting overdiagnosis, because overnight millions of people in the US became hypertensive all of a sudden simply because the threshold was changed. Thanks for that.
I think another example, and that I can think of as well, is the concept of pre-diabetes, that now we're already labeling a person with pre-diabetes and they may never actually progress to diabetes. However, now they have a label and now they have an inherent concern that they're going to be developing this. And it's almost as if it's a automatic, we have to travel down that pathway because now we have the label. And so I think it also puts a lot of mental stress on patients when they're just ultimately labeled based on a few test results without having a formal conversation and talking about the risks, the harms, the benefits, or even how moving further down that pathway can be prevented or at least avoided for longer term.
Yeah, that's a really good point. I mean, if the only thing that comes from getting pre-diabetes label is that you are now on a medication for a longer period of time without any necessarily improved health symptoms or outcome, that's questionable whether that needed to be known 5 years before your symptoms developed. And for sure, people who should be screened for or are being suggested for pre-diabetes screening will have other cardiovascular risk factors or other sociodemographic risk factors. I mean, these should be addressed proactively, and the answer is modification of risk factors that are possible to modify, and not subjecting someone to the illness model of existence before they necessarily need to be. Thanks. I appreciate all of the very good comments. Did we cover the one about medical student syndrome? Yeah, okay, right. And so maybe we can, we have only about 8 minutes left, but if there's no further comments, our goal was to give you 3 different perspectives on this issue of overdiagnosis, and we know it's a difficult and a vexing one and a very problematic one to tackle, but there's only one way to address it, and it's to start the conversation. So our goal today is, if you meet someone in your team, or a patient or healthcare provider or family member, I mean, I don't think there's much benefit in telling someone, I think you've been overdiagnosed. That will not always be well received, but just to think about the potential harms of what we do in the well-intentioned desire to catch things early and to establish a diagnosis when in fact there may be harms that are not appreciated by all parties. So Marisa, Carina, anything else from your end?
I think you summed things up really nicely, Dr. Lang.
Yeah, I agree.
Well, it's been a pleasure working with you again on this presentation. It's so nice to see you. Good luck with your emergency medicine residency, and looking forward to other opportunities to share our views on overdiagnosis with other audiences. And thank you so much to VMA and Professor Al-Ansari and all of you 25 who have joined us in this presentation.
I think we have
one
another
more
comment. Yeah.
Yeah, it should be taken to policymakers. Well, that's a really good point, Dr. Altan. I mean, I think one potential, you know, we ask people to sign a consent before appendicitis, before appendectomy, and I would argue that the risks of undergoing a PSA test, if you're otherwise healthy 55-year-old man, the risks of the downstream harms are greater with a PSA test. So maybe we should look at a policy where, sure, if you want to have a PSA test, go ahead. But if the guidelines recommend against it, and the Canadian guidelines recommend against it, either it should be paid for some other way than the public purse, and there should be a consent form that the patient fills out if they're going to agree to have the test. It can't just be a routine thing that someone just ticks off. And of course, our system sometimes stresses that to tick off all the boxes when it might be causing more problems. So very good point about the policy dimension and how maybe to protect physicians who want to reduce overdiagnosis, protect them from the medical legal risk. A very, very insightful point to end on. I'd like to thank everybody again, wishing you best of health and good wishes, and enjoy the rest of the conference.
Yeah, enjoy. Thank you everyone for coming. Shukran.
Thank you. Thank you for this opportunity. Enjoy the rest of your evening.
Bye-bye.